maneuver you guys need to do until the patient neck got fixed, and then you do your final and definitive work later on. Spinal cord management in general, this is our common principles. You have to immobilize the patient. You have to do neurological assessment. Be sure those patient doesn't have bed sores. Be sure those patients get DVT prophylaxis, neuronutritional support. Those are just general things you have to keep in your mind, nothing specific. Now it's the same thing I mentioned before. Um, um, to be honest, from here and move on, when I'm talking about management, um, um, different kind of fracture, this is not for your exam, because someone else will take care of it during um, in real practice. But you have to just recognize um, and have a common sense what kind of fracture in general as a names is there, and when really you need to rush those patients to spine surface so they can fix those injuries. Okay. um, Always cervical spine start with the C1, and C1 there's a fracture called Jefferson fracture, which is fracture of anterior and posterior tubercle in both sides. And this is really what I need you guys to know. There's a Jefferson fracture. Don't need to know the classification at all. This is just extra for your knowledge if someone interested. But in all the fracture, if the fracture is stable, then most likely either doesn't need intervention or can be treated in a collar or a brace. If the fracture is really bad or unstable and causing neurological deficit, most likely those patients need to go for surgery. In the middle, if it's borderline, it can be positioned in a kind of a little bit of invasive brace, like a halo, which has a ring on the head fixed with the bends in the skull connected with the jacket. This is just to keep in your mind. If you share a patient with the spine surface and you see this thing, you know what's for. So that's kind of a general principle. I don't need you guys to know the classification, when to do surgery, when to do conservative. This is just in general. Okay, that's C1. Surgery, that's general information, not for the exam. Surgery is that's the end stage when it's unstable. In C2, there is two kind of fracture. Just to know, it's called odontoid, the C2, and the fracture can be odontoid fracture, and it's fracture on the dens. Okay, that's what I need you guys to know. There is a classification you don't need to know. And in general, as I said, if it's unstable, causes spinal cord injury, needs surgery. If it's mild, treated with a collar. If it's in between, we put the patient in a halo. There is another fracture in C2 called hangman's fracture. When it's posterior, it's called hangman's. If it's in the dens, it's called odontoid fracture. And again, you don't need to know the type, but if it's severe, you get treated with surgery. If it's mild, you get treated with collar. If it's middle, we put them in a hollow fist. Okay, so that's C1 and C2. They are special. They have name. From C3 to C7, we call them subaxial cervical spine. Okay, and again, if it's bad fracture, would need surgery. If it's mild fracture, get a collar. If it's in the middle, it's hollow fist. And the decision in general, I don't need you to know this, but it's for your information. If it's morphology bad, if there is a ligament fracture, if the patient has a neurological surgery, most likely those patients will need surgery. And you have to know it because it's really quite often you get different um, uh, uh, trivial fracture, and those patients really doesn't need to rush them to and refer them in the middle of the night to the spine center. If then they can be just put in a collar and no rush. But if you have a neurological deficit, or the morphology is really bad, fracture, dislocated, if there is a ligamentous injury, this is all goes with um, bad injury, and those patients must like intervention. Those patients you have to be really definite about the C spine precaution, about not moving them, about rushing them to the spine surface. And again, on those patients, we have to be, really important about moving them around. You don't have to know this. This is a more advanced thing. Um, Thoracolumbar fracture, it's the same as the subaxial fracture, and there is a classification. Don't You don't need to know this. Um, the only thing I need you guys to know is this one, because you might see you see it in the file of the patient of trauma and with a spinal cord injury, and that's called standard neurological classification of spinal cord injury, and that's really important to be done when the patient get admitted, and it can be updated afterward. uh, and I think the most important thing, guys, to know um, is the Asia in bearing scale. This is really, guys, I need you to know. It's now get a popular um, uh, to be, similar for Glasgow Coma Scale. Glasgow Coma Scale is for head injury. Asia score is for spinal cord injury. It tell you about how bad the injury. It tell you about the prognosis, and basically it's divided in A, B, C, D, E. E if your patient is normal. A if the patient lost all the motor and sensory function below the injury level. Okay, so A and C should be straightforward for you guys. B, it's incomplete, and this patient has some sensory function, but they have a zero motor function. That's B. And then the C and D is a bit tricky, a little bit, because it's focus and the difference between them on the motor function. And I will explain for you guys how we measure the motor function. Okay. So basically, if more than half of the key muscles, the important muscles below the level of injury, has a grade less than 3, that's C. If more than 50 has a grade more than 3, that's D. And we grade the motor scale from 1 to 5. 5 if they have a full motor power, 1 if they have a zero motor power. I'm not sure if I have it here. Just give me a second. No, I don't think I have it. Okay. Um, 1 if they have no motor power. Okay. 1 if they have just a little flickering. 2 if they have just little um, they are able to raise their hand up. So 3 if they have ability to lift the hand against the gravity, that's called 3. So above 3 and moving forward, they get D. Less than 3 get C. So I need you guys to know the Asia impairment scale, really important. And you can just Google also the motor bowel scale from 1 to 5. So you need to know A, B, C, D, E, because If the patient A, that's mean he doesn't have spinal cord injury, he will be fine. If the patient has E, those patients have spinal cord injury. They have, if it's B, C, D, E, have spinal cord injury. Then if it's, sorry, again, if the patient E, that patient doesn't have spinal cord injury, B, C, D, E have spinal cord injury, then it depends on the severity. From D to A is the worst, because if the patient has a A, most likely 99% he will be paraplegic for the rest of their life, unfortunately. But he will be lucky if it's D, C, and less lucky if he is B. Um, I want to be sure, guys, you get the ASHI impairment scale and you understand it very well. If you want me to go through it again, I will. Is it clear, guys? The ASHI impairment, perfect. Okay. The rest are extra. You don't have guys to know about it, and usually all based on the motor and sensory exam. Um, Also, thoracolumbar fracture. That much. I need you guys just to know. Um, from T11 to L2 is really common to see a fracture there, because it's transitional zone between the dorsal and lumbar spine. And um, the decision for surgery, again, the same principle. If bad morphology, bad ligaments, bad neurological status, surgery. If it's mild, no surgery. And um, always in those patients, we need CT scan to show us the bone, and we need the MRI to show us the ligament and show us the spinal cord. Um, and the decision always based on the stability, and stability defined by posture, and be able to protect the neural element when you move and stand. Okay, it's nice to know this definition. Maintain normal alignment and protect the neural element under normal physiological load. um, this is really old definitions. I don't need you guys to know it. um, this is just show you some bad fracture. If you can see how bad this one is dislocated, this is completely abnormal. If you see something like this is really immediate intervention needs to be done. But this is nothing, you don't need to know this for your exam. um, you don't need to know this for your exam. This is for your life. Sometime even on x-ray, when you look at this is spine, you see the spine, and then all of a sudden it's moved here. This is again is really bad injury there, and need immediate referral, um, and immediate intervention. And usually we treat the dorsal lumbar with fixation and screw. Again, this is something to keep in your mind when you see a patient with trauma. You don't need really to memorize them for your exam. um, the summary, it's common. We maxillofacial fracture and cervical spine fracture. You have to take care to immobilize cervical spine in early evaluations, and to minimize any additional neurological deficit. Comatose patient should be treated as if they have a spinal injury, and if they are unstable until proven otherwise, usually CT scan, and later on we need MRI, because CT scan could miss the MRI. And we talked about the thoracolumbar junction is a common for fractures. And that's everything. And we'll leave floor for you guys if you have any questions to answer. So I think in general, I tried to summarize. I said cervical spinal cord injury is really bad and devastating, and we have to recognize their presence, because if we did not recognize that, that's could cause, you could introduce spinal cord injury to the patients, and the patient will be paralyzed the rest of his life, and that's devastating for everyone. You have to know, and there is an association, I don't care about the number, between spine fracture, head injury, as well as the maxillofacial fracture. Okay. It can happen everywhere, but two cluster happen and common, C1 and C2, as well as C6, C7. We see them with the maxillofacial fracture. This is really critical and important to know, and you have to suspect the presence of spinal trauma if the patient has neurological deficit, if they have neck tenderness, if there is another severe injury distracting the patient from focusing about his neck, and if the patient has a history of severe trauma. Always, we know early decompression is important for cervical spine, mostly done within the first 24 hours. Definitive repair of maxillofacial fracture, you need manipulation of the neck. That's why, and usually doesn't need to be taken immediately. That's why we delay them until we take care of any unstable cervical spine fracture. Should be done first. Sometime if there is a significant bleeding and you need rapid hemostasis and temporary stabilization of the facial fracture, can be done temporary until you take care of the cervical fracture. And This is something, yeah, those are the most important things um, you guys have to know. And then we talked about in general about fractures, when we call them stable, what we look at when we call them non-stables, and we talked about the importance of the HS score. Any questions? Okay, all the best, guys. Again, sorry, this one used to be a three talk. I used to give them 4 years back. Then it's a lot of knowledge. That's why I kept a lot of information for anyone wanna read more or interested to know more. But I focused on things you guys really need to know, and either for your exam or for real practice. All the best. And if anyone has any specific question, you guys could send it to me through your leader, and I'll be more than happy to answer them. Have a good night, and see you soon. بحول الله. السلام عليكم.